Welcome! Today, we're doing a clinical deep dive into Colpitis, a term you probably know better as vaginitis. We're going to break down the inflammatory process, get into the microbiology, the treatments, and really understand why this is so critical from both the clinical and a public health perspective.
Okay, so here's how we're going to tackle this. We'll start with how the patient presents. Then we'll get into the lab to figure out what's causing it. After that, we'll cover treatment, prevention, and the serious consequences if things go wrong. We'll wrap it all up with a few case studies to bring it all together.
All right, first things first. What does Colpitis actually look and feel like to the patient? Let's get into the clinical signs. So, at its core, what is Colpitis? Well, it's simply a state of inflammation of the vagina. It's not one specific disease, but more of a clinical syndrome, a collection of signs and symptoms that tells us something is wrong and we need to investigate. Now, the presentation can be pretty diverse. You have the more common signs like altered discharge or itching, but you also see more specific symptoms like dyspareunia, which is pain during intercourse, or dysuria, that burning sensation during urination. And then there's a really classic, though not always present, sign for one particular pathogen, Colpitis macularis, which gives the cervix a very distinct strawberry appearance due to punctate hemorrhages. What's really fascinating here is how the exact same biological process, inflammation, manifests so differently based on the anatomy. In the vagina, it's Colpitis, but you take a similar inflammatory process to the penis, you get balanitis. To the rectum, you get proctitis. It's a great reminder of how location dictates the clinical picture entirely.
Okay, so we have the symptoms. Now for the crucial next step, figuring out what's actually causing them. We need to identify this specific pathogen.
And this is the key point. Colpitis is an umbrella term for a reason. As you can see, the culprit could be a fungus like Candida, a parasite like Trichomonas, or a whole host of bacteria, from the mixed flora of bacterial vaginosis to classic STIs like gonorrhea or chlamydia. This is why a specific diagnosis is absolutely paramount. You can't just throw a general antibiotic at it and hope for the best. The therapy has to be targeted.
Now, for many of these bacterial causes, one of our foundational diagnostic tools is the Gram stain. It's a beautifully simple yet incredibly powerful technique that helps us differentiate bacteria right off the bat, which, of course, brings to mind, a time-honored microbiology joke.
Yeah, I know. But believe it or not, that simple staining procedure is often the first critical piece of the puzzle that points us toward the right treatment. So let's look at what those treatments are.
Now that we've identified our pathogen, we can finally select the right tool for the job. This is where medicine gets really precise, with pathogen-directed therapy.
And this table shows that principle of targeted therapy perfectly. Look at a standard Candida colpitis, a yeast infection. We start with a local, intravaginal therapy like clotrimazole. Why? It hits the problem at the source with minimal systemic exposure. But if that fails, or it's a resistant case, we escalate to an oral systemic drug like fluconazole. The dose, the route, the duration, it's all tailored specifically to the pathogen and the clinical scenario.
Treating an individual is vital, but to really get a handle on these infections, we have to zoom out and look at the bigger picture: prevention, control, and public health reports.
So, we're really looking at a two-pronged approach here. On one hand, you have bedrock principles of infection control in the clinic, things as simple as meticulous hand hygiene. On the other hand, you have mandatory reporting for the really serious threats. Why is puerperal fever notifiable? Because it's caused by a particularly nasty group A strep in postpartum women, and it can spread like wildfire in a clinical setting. Reporting allows public health authorities to track outbreaks and intervene immediately.
So what happens if these infections are missed, or ignored, or inadequately treated? Well, what starts as a localized issue can escalate into a systemic catastrophe with devastating, long-term consequences.
This is a perfect and frankly frightening example of what can happen. We're looking at the path of an untreated chlamydia infection. It's notoriously silent, often starting with zero symptoms. But from the cervix, the bacteria can begin to ascend, moving up into the uterus, causing endometritis, and then into the fallopian tubes, causing salpingitis. That combination is pelvic inflammatory disease, or PID, which can lead to scarring, chronic pain, and a significantly increased risk of infertility.
And it is absolutely not just chlamydia.
Untreated gonorrhea can disseminate through the bloodstream to cause arthritis or even meningitis. Syphilis can lie dormant for years before re-emerging to attack the nervous system. This is precisely why early and accurate diagnosis is not just about relieving initial symptoms, it's about preventing life-altering or even life-threatening systemic disease down the line.
All right, we've covered a huge amount of ground. Now, let's put it all together and apply this knowledge to a few quick clinical cases. Let's see how these principles work in practice.
Okay, focus on the buzzwords here. Severe itching is a clue, but that white curd-like discharge is the classic sign. Which pathogen screams that presentation?
Exactly. It's B. Candida albicans. That curd-like discharge, often described as looking like cottage cheese, is the textbook sign of candidal vaginitis or a yeast infection. The other pathogens on this list typically present very differently.
All right, next one. This is a question about the fundamental rules of infection control. 3 of these are gospel. One of them is an oversimplification. Which one doesn't fit?
The answer is C. And the key word that makes it wrong is all. Surgical drainage is absolutely critical for purulent collections, that is, abscesses full of pus. But you don't need to surgically drain every single kind of wound infection.
And for our last case, let's circle back to complications. We talked about one pathogen in particular that is famous for its ability to climb up the female reproductive tract. What's the signature complication of that ascent?
And that's it. The answer is C, pelvic inflammatory disease. This connects right back to that pathway we mapped out. It's the ascending nature of chlamydia that directly leads to the inflammation of the endometrium and fallopian tubes, which is exactly what PID is.
So we'll leave you with this final and perhaps most important question. The treatments we've outlined are the current standard of care, but we are living in an age of escalating antimicrobial resistance. How do we adopt these strategies to ensure they remain effective for the next generation? That is truly the challenge that will define the future of infectious disease. Thanks for joining us.